Okay, so maybe I should get started. Good morning, everybody. I have no conflicts of interest to declare, but I do have a few things to declare about this slide, which is that all of the data I'm about to talk to you about today was not generated by me. It was generated by my students, specifically, and my colleagues, Yan Wu, Linda V, Christina Raker, Justin Crawford, and perhaps most recently, Ms. Athea Zarir, who's just joined our lab. And all of the data that we have generated would not be possible if we did not have an ongoing and very supportive collaboration with 11 surgeons here at the Roth McFarlane Hand and Upper Limb Centre, who are shown here. In particular, I guess, the two hand surgeons, Bing Gan and Ruby Greywell, who have supplied probably close to 100% of the samples for which we use for our analyses. And of course, funding support from Canadian Institutes of Health Research, Plastic Surgery Foundation, and a variety of other smaller funding bodies. So I'm going to talk to you today about the matrix. Not so much this matrix, although you will know that in the movie, all Neo had to do was swallow that blue pill, right? And we heard a lot from Zolt about, getting the pill, right? So unfortunately, I don't have, and swallowing the blue pill I was able to free his mind, as it were, from the matrix. We don't have a blue pill to free your hand right now, but hopefully one day soon we will. So I'm going to give you a brief seminar overview. I'm going to be talking about the extracellular matrix, or the ECM, as I'm going to use it for short, in Dupuytren's disease today. So I'm going to tell you about what the extracellular matrix is, what it is not, what is in it, what does it do, how does it do it, and can we target it to treat Dupuytren's disease? And I'm going to try and fit all of that into 20 minutes, so let's see how I go. So firstly, what is it? So the extracellular matrix is the microenvironment that surrounds cells. And it, in the context of Dupuytren's disease, the cells that are surrounded contract on myofibroblasts, and these are the primary source of the extracellular matrix in Dupuytren's disease. Now, myofibroblasts secrete matrix, they adhere to it, and they contract it. The matrix promotes the formation of myofibroblasts. So if you consider the last 2 points, you realize that, of course, that this is a positive feedback loop. That if you have myofibroblasts making matrix and matrix making myofibroblasts, you end up in a positive feedback loop, which we sort of know as the fibroproliferative condition and hypercontractile disease of Dupuytren disease. So what is it not? What I hope to convince you of today is that what it is not is a passive bystander in the pathogenesis of Dupuytren's disease. The matrix is actually a major driver, in my opinion, of disease progression. And perhaps more to the point, the extracellular matrix in Dupuytren's disease is certainly not normal. So what's in it? Well, that's a big question because it's a very, very complex mix of a variety of proteins and other molecules. The matrix consists of collagens. Of course, we're well aware of type 1 and type 3 collagens, but in fact, there are at least an additional 10 kinds of collagen in the contracture cord of patients with Dupuytren's disease. There are fibronectin, including so-called oncofetal fibronectins. They're in very high levels. Heat shock proteins as well. Decorin, vitronectin, laminins, proteoglycans, glycosaminoglycans, a whole slew of growth and differentiation factors, of course, transforming growth factor beta being perhaps the most well-known, but also a variety of other tumour necrosis factor, insulin-like growth factors, specifically IGF-2, and a lot of other molecules. Proteases and their inhibitors, matrix metalloproteases, tissue inhibitors of matrix metalloproteases, a disintegrin and metalloproteases, some of them with and some without thrombospondin repeats. A whole bunch of these various proteases are all embedded in the matrix around these cells. Matricellular molecules, a particularly interesting group of proteins in the context of the matrix because these proteins exist only in the matrix, in fact only function when they are associated with an extracellular matrix, but are not structural components of the matrix. Their role in life is to mediate signals between the matrix and the cells. They're like molecular bridges, if you like, of changing cellular behaviours based on matrix-driven effects. And of course, there are a whole bunch of molecules that I at least am yet to appreciate, and I'm sure you're yet to appreciate as well. So I'm sure that there's much, much more to be learnt still about the extracellular matrix in Dupuytren's disease, even just at the point of trying to identify all of the components. So what does it do? Well, the Dupuytren's disease matrix, biochemically, growth factors, all of those other things, and biomechanically, and we're going to speak a little bit more about stress and stress-related effects in a moment, modifies the palmar fascia and the adjacent tissues to the palmar fascia. It induces myofibroblast development and contractility, as I mentioned to you before, due to these variety of factors that feed back on the cells. And of course, the matrix, again, is being made by these cells. And it dysregulates the gene and protein expression of these cells. And I am going to state, even though this is somewhat difficult to prove conclusively, that it promotes Dupuytren disease progression and recurrence and is a major player in both of those processes. So how does it do that? Well, it's complex, and there are complex interactions between extracellular matrix-associated reservoirs of bioactive molecules. These, again, can be growth factors, they can be proteases, they can be all kinds of various, both structural and non-structural molecules. Matricellular molecules, like I mentioned, things like periostin and tenasins and CCNs, CCN2 in particular, Wnt-inducible secreted protein 1, WISP1 is all CCN4, same thing. Molecules like that which act essentially as, again, molecular bridges between the cells and the matrix that's surrounding them. Biomechanical signaling that simply is mediated by the stiffness, the stress in the environment, and how these cells respond to that. And this is their environment. For example, let's have a quick look at beta-catenin in Dupuytren's disease. Now, beta-catenin has become very topical in this disease, and there's good reason for that. Beta-catenin is, of course, a major component of the canonical Wnt signaling pathway. Our group was the first to identify beta-catenin as an upregulated molecule in this disease. And of course, many years later, we've had sort of studies, genome-wide association studies, which have come in essentially from the opposite direction and identified a whole bunch of single nucleotide polymorphisms in genes which are in Wnt signaling genes and genes associated with that. And so we see mutations in the ligand, we see upregulation of the downstream mediator of many of those ligands, and so this pathway has become a bit of a hot topic in Dupuytren's disease molecular research. So beta-catenin is an unusual protein in the sense that most cells make it, most fibroblasts make beta-catenin, but when you look for beta-catenin in most fibroblasts, it's at vanishingly low levels. And some of the reason for that is that, well, vanishing low levels, at relatively low levels. And the reason for that is that the protein is constantly degraded. It's made, degraded, made, degraded, made, degraded, until some signaling pathway interrupts its degradation, not its gene transcription, and you get this upregulation of beta-catenin. Now, that interruption can be Wnt signaling, some called canonical Wnt signaling. It can actually be many other pathways as well, including our well-known and well-loved transforming growth factor beta signaling. Can also act through a sort of an adjunct signaling pathway to upregulate this intracellular mediator. So if that happens, so what? Well, what happens is that if beta-catenin degradation is impaired, you get cytoplasmic accumulation of this protein, it translocates into the nucleus, and it transregulates the expression of many thousands of genes. We've actually in the process right now of doing chromatin immunoprecipitation sequencing analyses on patients to try and identify all of those genes, and I can certainly tell you there are thousands of them, to regulate fibroproliferative disease. It does this in colon tumours, it does it in aggressive fibromatosis, hypertrophic scarring, and we believe it does it in Dupuytren's disease as well. So this is kind of old data now, but this is some immunohistochemistry for beta-catenin, some contracture tissue from one patient, contracture tissue from another patient, the adjacent palmar fascia taken about a centimetre away in the digit next door, which was at least visually non-fibrotic. And yes, all of the brown staining you can see is beta-catenin. And so I think it's fairly easy to convince you that there is a marked upregulation of beta-catenin in the disease tissue compared to the tissue in exactly the same patients, only a centimetre away, and they're visibly unaffected tissues. So we thought we should investigate this. We're going to get some tissues out of these patients. We're going to grow them, and we're going to look at what beta-catenin does in Dupuytren's disease. Should be a doddle. We'll knock this over in the weekend. So we got cells from contracture tissues, which we refer to as DD cells. It's not very imaginative, I know. Cells from the adjacent palmar fascia, like I showed you. So these are cells which are genetically identical. They are syngeneic with the DD cells because this is benign fibrosis, which we refer to as PF cells, palmar fascia cells. We also have a bunch of patients who come in for supply us with normal palmar fascia. These patients usually coming in for carpal tunnel release, and we screen them to see that they have no family history of Dupuytren's disease, and the vast majority of these cells act well, like normal palmar fascia fibroblasts, and do not act like the previous two cell groups. That's what I'll get to in a moment. So comparing all of these things, we thought, well, let's go and look at beta-catenin levels, because based on the tissues, we expect very high beta-catenin levels in the Dupuytren cells and very low beta-catenin levels in the PF cells. And that is exactly what we didn't see. We see that Dupuytren's beta-catenin levels are the same all the way across the blot here, PF and DD. These are patient mass. That's patient number 50, patient number 43, patient number 36. Fibronectin levels, really unchanged. Heat shock protein, 47 levels, really unchanged. Thought, okay, we must be doing something wrong here. What's wrong with our culture system that when we look in the tissues, we see this marked difference, but when we look in the cells, we don't see it anymore? And we came to the conclusion that maybe it was about the culture substrate. Connective tissue cells are very sensitive to the stiffness of the matrix in their microenvironment. Connective tissues can vary in stiffness. We usually measure stiffness in what's called a Young's modulus. And the Young's modulus is something like the provisional matrix of a healing wound. Is very low. It's less than 1,000 pascals. Right up to, say, scar tissue and probably Dupuytren's core tissue, which is something around the vicinity of 50,000 pascals. So it's relatively stiff tissue compared to normal connective tissue. But a tissue culture tray is 3,000 million pascals. So it's, I guess, a bit of a red flag to the physiological relevance of taking cells which are highly biomechanically sensitive, plating them on plastic dishes, and then trying to elicit useful information, because it's very difficult to do. So we thought, can we culture these cells on something that's a little bit more physiologically relevant than plastic? So we tried growing cells in or on collagen. Of course, collagens are major components of the fascia and of connective tissues, both normal and fibrotic, as I've mentioned to you. And all of these cells proliferate quite nicely on type 1 collagen matrices, to different levels, admittedly, but they all proliferate and they don't die readily. The cells are, in fact, very adherent to this collagen matrix, and the Dupuytren disease cells in particular display an enhanced capacity to contract collagen. Now, we're not the first people to show that. Many groups have demonstrated this, relative to both their syngeneic controls, which are kind of marginally more contractile than the normal CT controls. So the reasons are hard to understand. This is alpha smooth muscle actin cabling in a myofibroblast, and those red little sort of spikes you can see on the end of all of those cables are focal adhesions. Focal adhesions are essentially like the cellular sensors for the cell. They're what the cell uses to detect its matrix. Most matricellular molecules signal through focal adhesions, not all, but most do. And so the cell is well and truly attached to its environment. It's sensing its environment all the time and knows what its environment is doing in terms of its stiffness, its movement, all of those kind of things. So it's not surprising that this highly sensitive cell with all of these apparatus for sensing their environment don't like growing on a tissue culture plate. So when we put these cells in collagen, we can measure their contractility through the very standard, now quite old assay called a fibroblast populated collagen lattice, where you take a bunch of cells, you put them in collagen, you leave them there for 72 hours. After 72 hours, you take a little grass rod and you sort of release them from around the outside. And because these cells have converted into myofibroblasts, if they weren't already, and are very contractile, they rapidly contract that into a little tiny plug. So what an FPCL actually looks like is this. And so, for example, here's a comparison of some CT cells and DD cells. 2 hours after we've rung a little ring around them to let them contract, 6 hours and 24 hours, and well, I don't think I need stats to tell you that there's some differences in the contractility here. So essentially what happens is that at this level, the cells are very stiff, like they're pushing hard against their matrix, and then they get this release, and suddenly they can chug it in, and by the time they get to 24 hours, they're really not tugging in anymore because they've sort of reached equilibrium. And that's relevant because if we look at beta-catenin levels in this, we thought, oh, this is great. Look, we've got upregulated beta-catenin just like we see in the tissues, when the tissues are under stress, and then we release them. And the beta-catenin levels transiently spike and then just drop. We're like, okay, they did this over 6 hours, so what's going on here? So let's try the opposite experiment. Let's put them on collagen without any stress. So we compared them to cells just on tissue culture plastic, but we just put them on nice, soft, 1.9% type 1 collagen, just lay the cells neatly on top, let them grow. And we assessed beta-catenin levels in those cells. Lo and behold, 72 hours after they've been cultured, beta-catenin levels are almost gone. So then I've got some densitometry of that effect, and you see there is a statistically significant drop in beta-catenin levels. And just to remind you, these are the cells that have abnormally upregulated beta-catenin levels in actual disease tissue. So what this tells us, oh, and here's a bit of immunofluorescence essentially to prove the point. The orange staining here is beta-catenin. These are Dupuytren disease cells 2 hours after they've been cultured on soft collagen and 72 hours after they've been cultured on soft collagen. And as you can see that apart from a few adherence junctions up here, there's no beta-catenin in these cells at all. So the matrix regulates beta-catenin levels in Dupuytren disease quite clearly. Now, this gives us some technical challenges because how are we going to go about modelling a signalling pathway that's potentially very important in this disease if we can't grow them in a sort of a standardised substrate to do these experiments? We don't really know at the moment whether it's changes in matrix stiffness. Well, firstly, we had to go and check whether to see that this also, in addition to regulating beta-catenin levels, whether it might regulate changes in the expression, of beta-catenin associated genes. Now, by this time, we'd moved into something a little bit fancier. So we're now using something called a tissue train system. It's far from optimal, but it's better than nothing. Essentially, what it does is create a three-dimensional, essentially mini Dupuytren disease cord. It attaches to some little tiny nylon anchors. It's three-dimensional collagen, and we apply vacuum pressure to it to impose either cyclic or static stress, and therefore mediating the kind of stiffness that we can see hopefully in the hand, or at least approaching it, and essentially kind of works like this, whereas the vacuum pressure rises, that's the little matrix sitting up the top on here, it gets dragged over the top of this loading post and stretched out, and of course as you drag it out, it gets stiffer and stiffer and stiffer. Actual trays look like this, and as you can see there are the little Dupuytren cords all sitting in here. You can do them in sextuplicate, which makes it kind of useful for doing multiple analyses. So we did this analysis and we looked at a whole bunch of Dupuytren's and PF cells, and we looked at a bunch of different genes. Alpha-smooth muscle actin encoding gene, which is of course standard for myofibroblasts, matricellular molecule, periostin encoded by the POST-N gene, a growth factor, IGF-2, Wnt inducible secreted 1 inducible secreted protein 1, which is a matricellular protein, NRG1, which is one, and it's also a beta-catenin driven gene we've noted from our ChIP-seq analyses, a novel gene which we've recently discovered, which is neuregulin 1, which is also a beta-catenin driven disease gene in Dupuytren disease, and fibronectin. This is what happens if you look at gene expression without stretching. If you impose a 1% increase, a tiny percent increase, we start at 5% to take the slack out, and it goes up 1% every day for 7 days up to 14%. So that's barely that's 14% change in the length of the overall side of the culture. Simply that versus cultures that are unstretched, we turn the thing off. There we go. How do I get back? Shift F5. How about I just go to slideshow from current slide. There we go.
Here.
Got it?
There. One to the right, to the right. Yeah.
Thank you. Sorry about that. Essentially, what we see is this. So between a 2-fold and an up to 8-fold upregulation in gene expression by imposing a 1% increase in stiffness per day. That's how sensitive these cells are to changes in matrix stiffness. So, I guess in summary, the ECM regulates gene expression in Dupuytren disease. They're clearly regulated by stiffness and the type of culture matrix. Even a modest change can enhance gene expression levels, both of beta-catenin driven genes and many other genes. These findings, I think, suggest that the type of culture substrate that we use when we want to do analyses of signalling pathways in Dupuytren disease is critically important. So I guess I just want to finish on one last point, and that is that, therapeutically, can we target the matrix? If the matrix is driving the disease, can we target it? The answer, of course, is that we already do, and we use Zyflex or Zyplex, which gets rid of type 1 and type 3 collagens, which are, of course, major components of the DD ECM. That's a good start, but of course there are many other potential therapeutic targets in the ECM that we could be looking at. And although I've kind of run out of time, one of the ways that I think that we could go here is that we could couple collagenase with a whole bunch of myofibroblast-mediated therapies. So hit both the cell that makes the matrix and hit the matrix itself in combination and come up perhaps with more useful treatments for preventing Dupuytren disease progression and recurrence. So the take-homes. The DD extracellular matrix is not a passive bystander in this disease. It is a potent regulator of gene expression. Potential therapeutic interventions for Dupuytren disease should, in my personal opinion, be tested on cells grown on physiologically relevant culture matrices and not on tissue culture plastic, because it's almost impossible to interpret the data you get from tissue culture plastic. And combined treatments that target both of these things are probably the optimal approach, marginally over time. Thank you. Happy to answer any questions.